All right, it is 1 o'clock, so I think we can get started. Um, Except for that echo. Sorry, 1 second. Okay, we can get started for real this time. Hi, everyone. Thank you for joining us, and welcome to the American Indian and Alaska Native Tribal Opioid Response webinar series. My name is Jeff Ladolter, and I will be your point of contact for the Tribal Opioid Response Technical Assistance. This webinar series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which includes 10 regional centers and a network coordinating office. To learn more, you can visit our website, which is linked in the contact and support box at the bottom of your screen. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. The CEU request form is available for download in the files pod in the webinar screen, and I will be sending this form in a follow-up email to all who attended. If you don't need a formal CEU printout, you can also just email us for an informal email. It depends on what your certifying body accepts. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. SAMHSA asks us to evaluate our events in order to provide improved performance assessment and accountability, and this survey asks about your satisfaction with this event, and it will take less than 5 minutes to complete. Completing these surveys helps us keep bringing meetings like this one, and we would all appreciate you taking the time to get to fill one of these out. Attendees will be muted for the duration of this webinar. Please use the chat pod to share any questions and comments, and we can address questions at appropriate points during the presentation. If you have a question during the presentation, you can also let us know by clicking the icon at the top of the window that looks like a little figure raising their hand. We have a small group today, which is great. I hope you have questions that we might be able to help you with. And if we cannot, we can certainly follow up with a later call. So to get to our presentation, today the University of Iowa's Shelley Campo will present. She has focused her research on health communication and social marketing. Her work focuses on how to encourage more informed decision-making and to encourage healthy behaviors by reducing risk through identifying and attempting to influence individual, family, and healthcare provider variables that impact behaviors in a wide variety of ways in populations. And she is going to be presenting on health communication challenges. And I'm going to hand it off to her as soon as I pull up her presentation. Oh, I should say there are handouts available for download under the Files pod too. There is a PDF version and a PowerPoint version, which has all the links that you'll see in the PowerPoint here today. Okay, I think that's finally got it. Shelley, can you move the slides to make sure you can operate them? Okay, perfect.
I think I can. So this is great, and thank you all for joining. For those of you that I've been able to Google, I was able to determine that we have quite a spread in terms of geographic distance all over North America, lots of time zones, etc. So I'm truly sorry that I do not get to see you in person. Originally, I was supposed to be giving this talk at the Minnesota workshop in Mystic Lake, and unfortunately I made it as far as the Minnesota border and had to turn around due to bad weather. This is really actually more painful for me because I'm a communication and sociology trained scholar, and so knowing who my audience is, getting to interact in person is something I relish. It's very hard for me to talk to an audience who cannot respond other than via chat, but I look forward to trying to make this as personal as possible. For those of you who cannot see me, I'm about a 5 foot tall white woman of Sicilian heritage, and I grew up in upstate New York and lived in various places in upstate New York. And had a lot of actual early childhood education about the Mohawks and the Oneidas and the Onondagas, Senecas, etc. That was actually part of my elementary school experience, which I know is not true for many in the United States. I have been deeply committed to figuring out how to engage in social change, and I have done so through lots of work in health communication, health campaigns, and persuasion over the last 30 years. And I'd like to talk to you about what health campaigns are, about guiding frameworks for helping to make them more successful, and I'll talk a lot about social marketing. And I'll also engage with you around some opportunities and challenges that come along with each step in thinking about the process. I do want to say that no intervention, and that includes health campaigns, are ever magic cures. But they can work quite well in terms of increasing awareness, changing attitudes, and in terms of changing some behaviors. But we really need to dissect both the problem, which is understanding the health issue, and knowing your audience. And a lot of communication literature resides about the importance of knowing your audience in order to be effective. So we're going to proceed, and I will continue to monitor the chat room in case anybody has questions along the way that I notice. So what is a health campaign? And most people agree that it's far more than a one-shot kind of intervention. Typically, it's a purposeful attempt to inform or influence behavior ultimately. Normally, we want people to actually do something, to make a change, to maintain a behavior, etc. But rarely do we just want to inform for the point of increasing knowledge per se. We would like people to use it or share the information or think differently in some way. Typically, a campaign is a large audience, and we'll talk more about what qualifies as large, but it's more than an individual. It's thought about as within a specific period of time, although often the time period is lengthy. It's using a coordinated and organized set of communication activities, which can include, a whole series of rollout of various types of campaign materials, social media posts, events, etc. over time. It typically includes multiple channels, and this can include interpersonal kinds of interactions. It can include media, social media, workplace communication, and etc. And the goal is to produce a non-commercial benefit to individuals and society. And and here we are today talking about one of those important issues. So what is marketing? Because we're talking about bringing together sort of the social side of communication and health with marketing, which is really tends to come out of the commercial side. So marketing is, again, an activity, a set of institutions and processes that create, communicate, deliver, and exchange offerings that have a value for customers, clients, marketers, and hopefully society at large. But marketing typically talks about services or products, and they typically mean an actual product that you can buy. But commercial marketers understand that a lot of things, a lot of research has gone on into how to market effectively, and commercial enterprises have an awful lot more resources to figure out how to sell things. And what we can learn from them can be adapted for the social good and not just for commercial goods. So the general gist, and this is the overall framework, and I'm going to talk through each one of these as we move forward, is really thinking about what are the lessons from commercial marketing for social good in terms of how they think about things to be effective. What are commercial marketers doing to be effective? And they consider a lot of different factors as they develop campaigns. And they don't tend to actually shortcut it. They tend to really spend time and resources in each area. And they also consider there are a lot of moving parts that need to be considered in order to increase the likelihood that whatever you're doing is effective. And I want to walk you through each of these steps going forward, and I'll define them as I go. But it's really a mix of thinking about your audience, having a lot of formative data to make good decisions, considering what your resources are and how to best allocate them, thinking about what people have to give up, what other topics or commercial enterprises you're competing with, how you develop your programs, which in this case would be your campaign materials, and then thinking about how you monitor, process, and outcome evaluation. So one of the biggest issues when you think about what your audience is how narrow do you want to go? The more narrow you go, so those of you that may be healthcare providers in the room, it is far easier to change people's behavior if you're working with them one-on-one. You can have really in-depth, immediate feedback conversations about what their life experience is, what their healthcare history is, etc. And then you can deliver them the most efficacious recommendation that you can possibly come up with. And then your odds are actually better about actually having impact on an individual. However, the issue with health campaigns is that often we're in a situation where we understand we need to change a whole lot of people's behaviors. And so we're often pressured to go very large. But the larger that we go, the more resources we need to have in order to reach more people and do it effectively. So there's a trade-off going on between what is the balance of efficacy, potential efficacy of a health campaign, and what are the number of people impacted. So to have a national campaign, for example, you really do need a ton of resources to be able to do it effectively, because you're likely going to have to still develop materials for different parts of the audience. So think about the effect of trying to target a 5-year-old and a 90-year-old at the same time. It's very unlikely to work. So again, it's a tight balance. So as you think about who and how you want to segment, so we're talking about people with addictions largely, and most of the examples I will be giving will be around addictions. Are we talking about people who are not addicted? Are we talking about people already addicted? Are we talking about people who, the segment of those not addicted but of higher risk? Are we talking about, people under certain kinds of circumstances and certain kinds of workplaces? We know construction, for example, is or farming can be highly dangerous occupations, and people may be more likely to be prescribed medications that start them on a cycle of addiction. Or are we talking about who? Because often people always assume that the campaign should be directed to an individual and that that person is the behavior that we want to change. But sometimes it's other people within the social network or within a community that we really need to direct campaigns towards. So if that's policymakers, if that's community development people, if that's elders in a community or parents who might have indirect influence on other people or more direct influence on people, workplaces or healthcare providers, and those are just some options. So the who could be pretty darn broad. Commercial marketers are really good at understanding that when we segment, we don't only segment on demographic variables, and that's a common shortcut that people make. They assume that the only way in which to segment audiences might be on something like gender or age, but it could also be about current beliefs, readiness for change, or from a communication standpoint, I'm going to raise another one, which is communication styles. So there was a campaign that was done in Vermont, and I don't know the efficacy of all the campaigns that I'm talking about, so I'm going to use them as examples only of things that I think might increase the likelihood of the campaign being successful. But there are personality variables and communication styles that can be important to consider. And so this campaign was directed at parents to talk to their children about marijuana. And what's particularly interesting about it is the communication literature talks about the fact that there are typically 4 different parenting styles, meaning that not all parents parent in the same way, right? So many of you may already be maybe parents or certainly have family or friends with children in your lives, and you watch people interact with their children, and they don't all do so in the same way, particularly when it comes to talking about issues or discipline, etc. So there are as I said, there are 4 types of parenting styles that are pretty well documented in the literature in the United States. The first is an authoritative parent. Authoritative parents sort of are a little bit less concerned about emotional support, but very concerned about sort of their children knowing what the rules are and following them and not deviating. So you can imagine a conversation between a parent and a child in which they're concerned about the fact that the kid might be at risk of using substances, and they remind them of the rules, for example, but don't ask the child necessarily how they feel about it. And a authoritative parent, on the other hand, would be concerned about sort of both the emotional and putting forward the rules. A permissive parent would be one who just might ask how the child feels about it, but might not really convey what their expectations are for the kid. This is considered more of a permissive parent. And then the 4th type is a parent who could be relatively absent, neglectful, or somewhat uninvolved. But you can imagine that the motivations for that 4th type of parent are somewhat different than the other 3, and that the parent, him or herself or their self, is more motivated for oneself than for the child. And so there you have to make an appeal about why is it good for the adult to engage in this, not necessarily why is it good for the child as a motivation. So none of these styles are 100% right or wrong, and they vary in terms of cultural background. So I indicated I was Sicilian, so Italians are very likely to grow up in more authoritative households. In the U.S., are authoritarian households. In the U.S., the sort of more balanced emotion and rules orientation is more common and is often pushed. But again, any of them could, except the neglectful ones, could have good outcomes for children. But if you want to get to parents based on parenting style, for example, and you know there are different kinds of ways in which people talk to their kids, then it seems like what you should do is engage with that. So up so for example, if you, it's very different, message might be received differently if you are a different member of this group. If you say, well, talk to your child. Well, talk to your child might mean different things for different groups. So you have to kind of, pitch the message where they will receive it. So talking to them about caring about their emotional well-being will only resonate with some of those. Caring about conveying rules will only, resonate some with some of them. But you kind of have to pitch what their approach should be based on what might be acceptable to that group. And the Parent Up website and campaign actually did just that. And so they have a spot where you can select the quote that best matches your parenting style. And then they go on to give you advice that more squarely fits into what that person's parenting style is. Again, hopefully increasing the likelihood that the recommendations will be received and carried out, and that parents will indeed talk to their children about these issues, because we know it can be effective. Let me give you another example about thinking about segments. So this is from the state of Wisconsin, and in looking a few of you up, I know that that some of you, I believe, are working at least in various communities within the state of Wisconsin. So this one is interesting because it's broader than a tribal nation. So it's talking about all Native communities within the state of Wisconsin. And so you can imagine, again, that the efficacy might be better if they were geared more towards specific communities than if they were geared toward the statewide. But there was a decision made to sort of balance it out and be a little bit more broad with the way in which they were doing this. Any questions about the segmenting part or thinking about the audience? I'm going to assume you're all nodding, that you're just very happy and ready for me to move forward. Okay. We will do that. Thank you, Leslie. All right, so the next part is about thinking about pre-programmed data gathering. So any good communication campaign starts with really knowing about your audience and knowing about your health issue. And so you have to do a lot of work to figure out who they are and what you know and how best to pitch the message, etc. So this could be data that you already have. So communities have data maybe about healthcare claims or service use or incident reports or other kinds of things. You might have had surveys in the community about this. You might have had focus groups or done interviews or just collected customer service data that you can look into. But it can also mean new data collection. Again, you could design something specifically for this purpose to figure out, again, those factors of what's the most important thing to focus on in this campaign and who's the most important thing to focus on. So you could start to collect stuff that's done. The other thing that is a good time to think about if you are collecting new data is to scan the landscape for what campaigns already exist, particularly those that might be more similar or more likely to resonate within your communities and for which there's some data available to tell you whether or not they were successful. And it's a good chance to get some feedback on those campaigns before you just adopt something. So one of the challenges is when people are developing campaigns is often they're funded by small grant mechanisms or states or federal government where there's extreme pressure to rush to the product. But the problem is if you rush to the product, you might not actually be as effective as you might be. So we often get overconfident that we know our audience or we know the problem. And funders often do not want to pay for data collection. But again, just because something worked in one community does not mean it will work in yours. And rushing to get something implemented can actually cost more money than actually doing some more upfront work. But again, this is kind of one of those tender balances because I do understand, and I work a lot in communities, that there is a lot of pressure to move along quickly with something. And the problems are escalating. But to be effective, you really, again, have to do a lot of homework up front to make sure that you are getting it right. The next challenge for most communities doing social marketing campaigns is that you very rarely have a lot of money, time, or personnel. So resource management to make campaigns effective is challenging. And you certainly always have to work within your budget, but you also have to allocate within your budget or find ways to bridge to other partners who can help you so that it hopefully increases the pool of available resources that you have available. But there is never enough money to reach, every channel and every part of your audience. That is extremely rare. So most, campaigns in communities and within states they have under $30,000 budgets. In many cases, I have worked up to $5 million on budgets, but that is truly an exception and not even close to the norm. So this is a huge challenge, and I will carry forward this as we move ahead. Another challenge is that social marketers and commercial marketers recognize that if you are offering something or trying to sell something, that typically it means giving something else up in return. So you have to, in a commercial world, you're going to a different provider which had different benefits, or you're on a different medication with different risks and benefits. In the case of substance use, particularly for those people who are addicted or who are users, there are benefits that people experience from those things, and it is very hard sometimes to get people to sort of recognize, and it's good to sort of acknowledge the elephant in the room, particularly for those that are addicted, that withdrawal is hard. It takes time, money, emotions, and often there are a lot of failures. So we're asking people to do something in that case, which will benefit them in a number of different ways, but recognizing that there's an exchange for the person or for the community is certainly another issue to always be thinking about. So what are people giving up, and how do you convince them that what they're giving up is actually worth it? There are also challenges in what marketers talk about in terms of competition. So we have a lot of competition with particular kinds of workplaces, for example, where the work inherently is risky and people may end up on using substances because of the environment they're in or because of the injuries they experience on the job. And we are constantly competing with commercial products that are not always our friends. So some of the opioid crisis has certainly been caused by substances that were marketed heavily by pharmaceutical companies. And let's face it, they have an awful lot more money than we have. So that is one source of competition. The other source is that if I talk to any of you, you would readily admit that substances are not the only problems in your community in terms of health issues. And again, when you're back to the resources with the limited pie, you have to convince people to put their money here and not money somewhere else sometimes. And so we end up with an internal competition going on for attention to cancer or childhood vaccinations or, other kinds of health problems beyond this particular one. So one of the challenges is, again, thinking about how to expand the pie so that we're not engaging in the internal competition that we would like to be in community health. Questions to this point before I click? Okay, I will move ahead. All right. One of the other problems we have related to competition is that people do not trust the government. They do not trust science. And we have a system in which we're embedded in problems that where we are up against commercial marketers who readily lie. So, we've known about the problems with tobacco and deceptive marketing going back, 40, 50 years, and eventually ending up in the tobacco settlement. We recently had a settlement in Oklahoma with Purdue Pharma around opioid prescription use and bad marketing practices. And we have states now trying to curb problems with banning teen vaping or, raising the level of product buys. But on the other hand, we have, states legalizing marijuana use that is going to make it more readily available to people whose hands we don't necessarily want it in. So again, we're dealing with commercial interests and other interests that are not always forward first with the health-related concerns that we experience. We also have conflicting scientific information. So I always think about these as they relate to issues of diet. We see it with other kinds of things like controversies recently about whether or not people should be taking aspirin or not if they're a higher risk for heart-related problems. But the recommendations around food just always fascinate me. So, one day you can eat eggs, the next day you can't. Some days eggs are worse than cigarettes in some prevention magazines. I'm not sure that that's true, but again, we got this sort of constantly changing and competing set of information. And the problem is people carry it into the next area. So if they don't believe in science and they think that they're getting conflicting information all the time about health issues, they assume whatever you're telling them is going to change tomorrow. Unfortunately, there are probably parts of that are correct because we have constantly changing scientific information, but I don't think we're suddenly going to come out and find that the benefits of opioids for most communities outweigh the risks. And here's another example about thinking about the government as it relates to lack of trust. So there was a story in the New York Times about 2 years ago or a year and a half ago that talked about how there had been clear evidence that the alcohol industry had been pressuring the National Institute on Health to fund studies, and they wanted to fund studies of the benefits of moderate drinking. So again, it's putting the corporate interests into NIH in a way that nobody likes to see, except corporations, maybe stakeholders. We also then end up with governments sort of, taking scientific information out of context. So there was a California judge about a year ago that ruled that coffee needed to come with a cancer warning. But if you start to look at the scientific evidence around that, the amount of caffeine you would actually have to absorb would be phenomenal. Very few people would encounter that. And at the same time, they were releasing studies talking about how coffee naps, and in fact, actually, I sat in on a webinar for CDC for regarding healthcare providers or folks who do shift work, that there are some benefits to taking coffee right before you actually have a nap. Because when you wake up, you will actually be a little bit more awake, and that can help with people who work overnight shifts or particularly long shifts. So again, this is a much more complex issue than the ways in which the government might want to interpret it, but the public is also then getting very conflicting information about what is and is not healthy, and when they start to distrust, then again, it carries over, unfortunately, to us. Who are trying to convey whatever the latest healthcare evidence is available. There are also a lot of challenges and opportunities in price. So in the commercial world, obviously the price is the monetary cost, but the price in a social marketing context can be about the size of the ask. So what is the scope of what you're asking them to do? So are you asking people to get a flu shot once a year, which seems like a relatively quick ask? These are the screenshot is of dietary guideline recommendations that came out from the government a few years ago, telling people, the average American, what should be eaten or consumed by an individual person. But the document is 118 pages long. So it's not one ask, it's many, many asks. And it's also asking people to read a ridiculously long document, which most people are not going to actually get through. So, we need to think about what it is, what's a reasonable scope of ask, what's believable, what will be acceptable, what will actually produce change, and be realistic about what it is people are willing to do. So specific asks are better than general ones. So, eat healthy is really vague and people do not know how to interpret it. Limit your, soda intake to, one a week, for example, is a much more specific kind of ask. So it's, we need to think about, again, what is it we want people to change, and then working down to a level of change that people will think about. And remember, again, you have to think about in that ask what it is you're asking people to give up in exchange for that ask. So people are often giving up something that they like or has benefits or makes them feel good in order to do something else. And it could also be time. So if you're asking people to go to meetings, to go to support groups, to see healthcare providers, that's time they're not maybe doing something else that they enjoy, but overall might be good for their health. But it is very important to think about what it is you're asking and what it is the products are that you're selling. In 2017, there was an article that laid out all kinds of possibilities of what an ask could be. So asking an individual to change behavior, asking people to call a hotline, participation in an ongoing program, thinking about a tangible good or commodity. Could be something like a condom, for example, which is still a tangible good or commodity with a public health benefit. Directing people toward another, which could be, a service organization, it could be a healthcare provider, a health system, an EAP person in a workplace, etc. directing people toward training, directing people to more tangible goods, which, for example, septic systems in environments where they don't have them, has a lot of public health good. Asking for positive feelings, asking people for changes in attitudes, knowledge, or intentions, or improved health or societal goods. You might have a whole bundle of services that you're suggesting, or the product might be to learn more about message content. And often more and more campaigns include a call to go to a website so that there's a lot more information that can be presented there in a much cheaper way. So I just noticed the note from Stephen, and I'm very sorry I didn't see it earlier, but I agree, conflicts of interest and political agendas are a real risk. I completely agree. And I think we have to be careful of those as we think about what the product is that we're trying to push and what our motivation is for pushing said product. And again, we want to be as honest as possible about where our conflicts are as well. All right. So I want to show you a couple of examples so that you can think about product and ways in which you can talk about drug use. So this one is from Pennsylvania. And again, I want to remind you that all these pictures of websites, there are live links embedded so you can learn more about them. So what do you think that the ask here is? So it may seem straightforward, right? The ask in the sentence is not to share drugs. So that in and of itself doesn't sound like a high cost. But what other costs are we not considering in this ask? Care more, raise awareness, absolutely. Um, not sharing is about potentially being conscious that the sharing is illegal. Yes, Allison, yes, not having family members or friends having access, which can be hard. If you've got a family or member or friend who cannot afford medications that she or he may have needed access to, which might even not actually include prescribed medications, it can have some social costs to say no under those circumstances. So it's not always easy to say no. Any others? Yeah, there definitely is a financial undertone to this too, and again, various kinds of ways. So it applies that people have enough money, for example, to get financial or have the financial resources to get medication in other kinds of ways. And we know unfortunately a lot of people are not insured. Um, and if you're throwing out drugs or, I will say disposing of them properly at the appropriate drug drop points, that's medication that's leaving the system, which is a benefit, but it's also prescription drugs that cost money. And so you're also giving up the cost of those. Anybody else? All right, I'll go to the next one. So this is a Utah related ad. So what's the ask here? Not to use opioids. Yep. Think about less addictive treatments. Jeff's asking who it's actually intended for. And I think that's an interesting question. So is it about the injured person, or is it actually about potentially the prescriber? So asking providers not to actually do it. I think the thing in the corner suggests that it's probably more the patient, because it says use only as directed, which would not be the provider, but I bet that there's something in there too that's kind of implicitly poking at providers. And super prescribers, yes, certainly another group. The other part of the ask, and again, this is related to the exchange part, is potentially asking people to live with pain for a shorter period of time that maybe is higher than they want to experience. But it's because of the long-term benefit of medications that can be prescribed under those circumstances are far less likely to be addictive. And some of that is also getting over belief systems, because we know that, you know, in not all cases are opioids actually more helpful in curbing pain than other medications. Some cases Tylenol may actually work just as well, but people believe that something else is going to work better for them. Yeah. So, yeah, again, there's sort of a little bit about who is this for here. Because you see a person falling, which makes you think it's the person with the injury, but in the corner you see the use only as directed thing, which, you know, again, could be more provider oriented. So it's not necessarily a bad thing if it taps both audiences, and we'll talk a little bit about, you know, unintended effects of campaigns, and some of them are positive. So they could have been purposeful in going after both providers and potential patients here, or they might have only thought they were going after one, but in reality, actually, they get the benefit of the other group also thinking about this. So that, again, that's not necessarily a bad thing. Any other comments on this ad? All right. Here's the next one. This is from Delaware. And the ask here seems relatively straightforward. It's explicit about calling 911. So obviously these are potential bystanders who might have seen somebody. But are there other parts of this that are also part of the consideration? Yeah, so there is an emphasis here on being proactive. They are trying to reassure people here that they are not going to be arrested if, you know, the person with them, for example, is also using, the one that calls. So Stephen is right that, again, we're turning this more and trying to turn it more into a medical issue than a crime. But it sometimes is very hard for people to want to call under those circumstances. So the audience here may be people that would be more hesitant actually to call. But again, it might work more broadly reminding people to actually call and not just, run away if they see a bad situation or assume that somebody else is going to call. This campaign is from New Hampshire. So what's the ask here? Yeah, get help if you need it, and that this call center could potentially refer people to services. Yep. Yes, a little bit of stigma removal. Help. Yep. Yes, definitely there is a little bit of different recovery paths in here too. So again, some options available, which is a nice thing. And yep, hope, support, and pathways. Excellent. All right. I'm going to move out of these ads a little bit and then talk about some other steps in the social marketing process. I do want to say, as you think about your messaging, there's a lot of things that you need to consider. So I'll talk about 3 sets of these. So the importance or and lack of sufficiency about knowledge, and I'll move to that quickly. Health literacy concerns, because often the information we provide to people is not done so in such a way that they're able to understand it. And then I want to talk a little bit about the variation and options for different types of emotional approaches. And historically, with substances, we often go straight to fear, but fear is not always the best, and there are lots of options from which to choose. But you need to think about these kinds of things, not just in what you say or what words you use, but it's also in the pictures you show. It's in the sources you use for information, etc. That again need to be carefully considered as you craft any materials that you will use. You know that many of you know this better than I do, but knowledge alone is not sufficient. And so people are motivated by different things. They live in different cultures and they live in extremely different environments. And so one of the things we always have to think about is the environment conducive to promoting the change? And if not, is there a way in which to change the environment to be more helpful? And again, that's why you shouldn't always focus on individual behavior change, but focus on people with power to make changes that control the environment in such a way. You also have to pitch messages about things that are realistic given the circumstances in which people are living in. So if you live in an area with a lot of money and a beautiful playground and ready access to healthcare providers, then telling people to go access healthcare providers might be a very reasonable thing to do. I've done some work in Micronesia with Pacific Islanders, and I've been to Chuuk, which is a collection of islands well into the Pacific. And frankly, getting to providers from some of these islands is a very lengthy and sometimes insurmountable task for people. And so trying to figure out other ways in which to get people information or resources that don't require physical proximity is of great concern there. But I do want you to think about where the campaigns need to be directed and how can we work with this. So, we use the example of campaigns directed potentially at healthcare providers to make sure they're not subscribing. If some of the addictions are coming out of prescriptions and their workplace related injuries, is there things we can do with workplaces to make them safer? And to encourage changes in those workplaces that will result in fewer injuries and therefore the need for fewer pain medications, for example. So think broadly about, again, what your options are and what the environment will entice. I spent 10 years on a health literacy panel for NIH, and so I'm also extremely interested in health literacy issues, which intersects with health communication. But the reality of the changing nature of medicine, the level of ownership or obligation of patients and their families as compared to the health system, the number of things that people need to be aware of, the move toward personalized medicine, et cetera, have all kinds of implications for patients and the general public. And so we have moved to a system which is great. You don't spend as much time in the hospital, for example, with a heart attack. But that means that the family suddenly has an awful lot of obligation in which to, if family is available, but somebody has to be available to help those patients because they're not ready to take care of themselves at the point at which they're dismissed from the hospital. We have had a proliferation of prescription drugs in the last 50 years, from well under 1,000 to more than 10,000 and expanding all the time. And so it's not just patients, but providers are not up to date all the time in the available medications available, and therefore might not be prescribing the best or the latest, et cetera. And so pharmacists can play a role there in communities and helping with those kinds of things too. And then we rely on the patient to be able to be self-educated and not necessarily engage in a system on one-on-one communication with healthcare providers where you can really gauge more carefully about whether or not the person is actually understanding the information that they're being given. And a lot of the materials that are being provided in a lot of places are written, and there may be language barriers, reading barriers, barriers of access to the internet or to telemedicine that might be more helpful. So, again, we often see widening disparities under the new age of science because those that have all the resources can gain more knowledge and information faster than those that cannot, and that's an unfortunate outcome. So health literacy is the ability to obtain, understand, and use health information, and we know there are widespread disparities with this. So again, the nature of the health system is changing, but if you have to know what 10,000 drugs are, that requires a lot more health literacy than, say, 650. And the intersection of we now know about genetics and environment and individual factors and epigenetics, et cetera, makes it very hard for even healthcare providers to keep up with that information, nonetheless, their patients. There are three types of literacy that influence health literacy, and they include prose, which is just being able to search and understand a written document. document information, which is the ability to sort of look at a couple of things simultaneously. So searching on the web, for example, for information, being able to use it, being able to combine information from multiple documents requires a larger degree of health literacy. And then quantitative literacy, which is basically, math skills and ability to interpret numbers, tables, etc., are the third form. So there have been 2 national assessments of adult literacy, and these are still really considered the benchmarks. And I hope at some point in the near future they will be repeating this study. But in 2003, it was done with 20,000 adults in the United States. And so very large sample, good willingness to look across and then try to figure out. And then figure out where people fit on the continuum as a general population of adults, and then looking at subgroups. And just at a basic swath level, without, recognizing that certain populations, such as older adults, people in particular ethnic groups, etc., are more likely to have lower levels of health literacy. The entire population actually in the United States is very bad about literacy in general and health literacy specifically. So less than 15% of the adult population was proficient in all of those areas. So we still have a fair number of people in the United States who cannot read a bus schedule in order to be able to make it to a healthcare appointment. And certainly we don't have a lot of people who can discern and use information that they find on the internet and be able to digest it, understand it, critique it, etc. So it's certainly a huge issue as we push more and more information out. But higher and higher levels of literacy and health literacy and digital literacy are required to actually be able to get to that and use it appropriately. I want to go back to some examples. Stephen, I think it actually, studies that have been done of smaller subgroups suggest that we have not seen significant changes in literacy levels. And in fact, actually in quantitative literacy, we're likely getting worse. So it's a good question. All right. I want to shift gears a little bit and talk about emotions. And so I don't know, I'm not going to have time to actually show this, but the Truth Campaign, which is funded by the tobacco settlement, actually, has been doing a series of ads around opioid and prescription painkiller addiction. And I'm assuming some of you have seen these ads, but they're readily available online. And they're basically individual testimonials, which are heart-wrenching, about, how desperate people are and what this addiction has been like for them. And I'm sure you can imagine these because it's been a common theme in substance use advertising for a long period of time. And ads that create fear and disgust and anger, the sort of the negative fear of these, can be very effective at creating a good sense of severity and susceptibility to different kinds of health conditions. But often they don't come with strong efficacy messages, meaning, is there a solution that will actually work here? And am I capable of getting that solution? In order to have a positive outcome. And so both self-efficacy and what's called response efficacy are really important. I'm not saying never use these things. I just think they're often overused or the only thing that people consider when they're designing ads around substances of various kinds. And certainly there's a reason why people want to avoid threats, but they also, particularly in some communities and some populations, they're tired of hearing everything that's horrible. And frankly, they want to hear messages about empathy and hope and not just about tragedy. And so I encourage you to really think about a range of emotions. There was an excellent TED Talk that was done 9 years ago by Melinda Gates of the Gates Foundation. And she was talking about a variety of things about why Coca-Cola is so effective as a commercial marketer and what it is that nonprofit causes really can learn from them. And there are a number of great messages in here, and I encourage you to watch the free video. It's about 20 minutes, if I remember correctly, because it covers a whole lot of things we're talking about today. In terms of how Coke does things. They also, use a lot of data. They're constantly making improvements. They work incredibly well with local communities. So there's a participatory element to this too. But her main point when it comes to thinking about what the message is and how Coke sells its products so well is that the overarching plan worldwide is what they are selling is happiness. And so if you go back and look at Coke's ads over time, they're all about sort of happy scenarios, happy places, people feeling good, celebrating, joy, like pure joy. I mean, so Coke has commonly placed really great ads, for example, in the World Cup. And tried to come up with music and images, etc., that really play off that happiness thing. So the point that Melinda Gates makes that I completely agree is, which message are you going to pay more attention to, right? Especially if you come from a place where happiness is more rare. Maybe you encounter a lot of poverty, poor circumstances, etc. And so the need to give people an alternative that sounds like it's going to be great is not a bad thing to consider. So think about the aspects as you're choosing emotion and emotional appeals, to think about the entire toolbox, all the way from the negative emotions to the positive, and not just assume that your only choice is on the more negative side. Questions about that? Okay, I'll move up. Jeff is typing. Well, I would say some are not as overtly negative. I agree. The majority of them are negative. The guy following on the bicycle was not exactly, it was not gripping with fear or in the same way that the truth ads, which I did not show, do. But I think it's the selling of the positive outcome rather than of the addiction or whatever. So you want to sell you start to sell the parts of the need to go through treatment or to avoid these things so that you can have, you can experience more of the positive benefits of time with loved ones, for example. And I have seen a little bit of that, but I agree. When I was searching for these, mostly I found one negative thing after another. Okay. All right. As you think about that toolbox, which now has all kinds of emotions in it and different kinds of messages and things to think about, you have to think about where you're going to put the information. So we think about these as channels. So be careful about what the latest and the greatest is. Does not necessarily mean where you should be placing. You also have to think about what your budget will afford. And so lots of social media is going on and lots of causes create websites, but they often have very few followers. in the 30s is not particularly high, but is typical. Who is following might matter. So if you're really getting at the influentials that way, it might still be worth your time, but you need to think broadly about what's available. So you need to think about giveaways. You need to think about traditional media. You need to think about events. Guerrilla marketing are often events where you do something sort of wild and bold and it causes people to pay attention. You can again think about interpersonal kinds of campaigns where you get people into the community who regularly, their job is to engage in conversations about this. That's another form of dissemination. But you want to think beyond that stuff. Posters are still viable. Giveaway materials and t-shirts that people like. Again, it's a way to spread the message and also give people things that they may use and need. Ideally, if you start giving away items, you want to give away items where they're used publicly and are easily read. But think too about more traditional things. Billboards can be in communities can be very effective because if they're in high traffic areas, either foot or car, people will see them, and exposure is definitely part of the issue. One of the issues that we have now compared to when I was a child and I'm now in my 50s is that we've had a proliferation of media and placement, and on the one hand, that's great. It's an opportunity. On the other hand, it's hard in a lot of audiences to find somewhere that everybody goes to. In more rural communities, that actually can be radio. There are a lot of people who certainly still listen to radio, and everybody's listening to the same channel because they want to hear the local programming and the local news. But we have to try to draw people's to where they're actually spending time and make sure we're placing in places that people will be exposed. But the cost of these vary wildly. Another issue with placement that we need to pay attention to, and it also has ramifications for the messages we design, is that we have very, very short attention spans as human beings, and the attention span is decreasing rapidly. So if you think about how long it takes, if you're reading something, to get distracted by the person who walks in the room or your cell phone beeping, or other obligations that are going on, or just competing thoughts about what you have to do in the day or who you have to help. Thanks, Stephen. I appreciate it. You've lost it. So you have to try to figure out what the soundbite is that will fit within an attention span that people have. So you got to think about shorter messages. You have to think about things that will resonate with people in a fast way so that they'll be inspired to want to read more. But we often assume now we have unlimited space and therefore our messages should be really long. That's not true. So think about short, quick, and do a lot of testing to see if in natural environments people will attend long enough to pay attention. I'm taking my own advice and moving on. Another big problem, I'm not sure how many of you are aware of filter bubbles. You may be aware of it in a different kind of way. Sometimes this is talked about the personalization with how we receive information. But computerized systems and vendors and credit card companies and everybody under the sun is now tracking with big data what our buying, search history, etc. has been around information. And then they're sending us information that is highly tailored to what our previous behaviors have been. And so the big downside here is that if you're somebody who searches the internet for health information and you go to a lot of sources that healthcare providers would not think of as particularly credible, for your information. So they're not searching your public health departments or your health services agency or the CDC or SAMHSA or NIH or anywhere else that you think is credible. Maybe they're searching out alternative ways of dealing with this that we know are not effective. That when they continue to search, that's the nature of what they will get, and they will never actually get to the credible sources that we want them to get to. And so you end up sort of trapped in your previous situation, and the only way out of it on the internet, the way out of it is to clear your search history on a regular basis. But the buying behavior one is harder because credit card companies have a lot of access to a lot of information. But again, people might not be finding your website, your campaign, etc., because they would not even get exposed to what it is we want them to see. And they may not understand what the actual science is currently or what the actual recommendations are. So their belief system will be competing with the information that you're trying to provide them. And then the last area I want to talk about is about thinking about how you evaluate campaigns. And it is important once they start running and you've placed them to be working on continuous monitoring and figuring out before you start what the outcomes are that you care about and how you will know if you're having impact. So if your campaign directed people to the website, you might know, for example, how many you can do analytics to figure out how many more people are going or how many more calls there are to your helpline. But you ideally want to figure out, were there behavior changes in areas that you wanted to see. And so it's important to track those. The one thing that commercial marketers do well is that they use real-time data to make adjustments. So if they're finding that nobody's calling the call center, if you haven't already bought where all your ads are being placed, maybe they need to be somewhere else. And commercial marketers would shift their resources to a different type of channel or a different time of day or something else to make sure that people are getting exposure. Or maybe developing some more posters or ads to put in places where people are more likely to congregate. Again, this is a challenge under various kinds of funding agencies because they want you to lay out everything that you're going to do, and they don't like when you deviate because it's they want you to stick with your current plan. But on the other hand, if you can start to make adjustments as you go, you may find that you're going to have much better effects. And again, in some ways, a much better use of the money. I want to talk to you again. So these are all of the areas that we talked about, and I spoke less about evaluation. And it's an incredibly important area, and I'm happy to come back at another point and talk about campaign evaluation possibilities sometime before the grant ends, if that's of interest to people. But it is important to really, learn from what you're doing and be willing to adjust, and then moving forward, you have better data in which to tackle the next thing. Because the reality of most health problems is they're long-term, and that's the great thing about health campaigns is they think about the long view, not the short view in most cases, and they become building blocks for future interventions and willingness to adjust. And the other thing I want to say is sometimes campaigns, again, have positive impacts that you're not expecting. They could get you new partners moving forward on the next thing because they see what you're doing and they like you and they like your approach, and they put you on the map. It could be the policymakers have been watching it and then start to think, oh, this is a more important issue in my community, and have a willingness to move forward. So there are lots of ways in which you can have, not straightforward outcomes, but you want to think about your intended outcomes, your unintended outcomes, what came out of it that was positive, what came out of it that was negative, how you'd make adjustments going forward, etc. Everything is a learning experience, and that's a great thing. So, questions, and I might have some answers, I might not. We've been looking along the way. The slide handouts that you have a couple more campaigns, including one from Virginia and one from Connecticut. And the ones from, I think the ones from Connecticut, which were public service announcements, have some more positive examples in them, but not completely. How else can I help? And certainly feel free to contact me after the webinar to talk about anything in more detail. Well, you all seem quite happy. So, you know, you must have be having a great day on your end. I'm truly sorry that I can't engage with you in a more multimedia way. Nothing else pressing. Ah, I see another something. And for those of you that joined a little late, if if you have any questions on the material you missed, certainly reach out about that too. Well, Dorothy, that's a very complicated question. Ah, so do you have community partners perhaps that are more knowledgeable about those kinds of things that might be willing to help? That's a very good idea. And a lot of college students are looking for internships and real life experience. Oh, Jeff is sending resources. So you want to think about the similarities that patient group might actually have, and then figure out again where they're going for information, where they're looking. So your web presence can be two things, right? It can be a clearinghouse of more information, or it can be a dissemination tool, as social media often are. We did not talk about this, but people are moving more and more toward visual information because social media is moving more towards short videos, etc., and not just typed words, for example. It's still not a bad idea, Dorothy, even if your population is pretty broad, to think about creating materials that might get to the subsections of your population. So not assuming that what's going to get to teens is going to get to the older group, and then develop some materials or messages that are more likely to resonate with that group, or really give some thought about what those groups have in common. Jeff, are we wrapping up? Do you have a wrap-up slide?
No slides, but I just want to thank everyone for coming. We've had some great questions. If you have any questions after the webinar, feel free to reach out to me or to Shelley. Shelley, thank you for putting your contact information up there. This webinar was recorded, so it will be available on our website in case you missed the first part of it. Otherwise, thanks everyone for coming. Shelley, do you have any other comments?
Well, it's a pleasure to meet you all in a very limited way, and I hope our paths cross again.
All right. Thanks, everyone. I'm going to end the meeting, and you will be directed to a GPRA post-event survey, which should only take 5 minutes to complete. Thank you all for coming, and have a good day.
Thank you.